here we go. I'll start with the patient and then I interpose some of my thought process during this. So we have a 9-year-old male with NF1, kind of diagnosed within the last 2 years because he's had a seizure disorder that's kind of come up in that time, and it's now well controlled. He's been found to have a brainstem glioma that's stable, a hepatic AVM that's stable, and ADHD that's been treated with various medicines in the last long time. But he was sent to us for concerns for PO because he's been having headaches, tachycardia, and hypertension pretty steadily for the last year at every doctor he's ever gone to. And then mom is really concerned because he's become more aggressive and he's quote unquote acting like a teenager. And he just balks all authority, and this is just getting worse and worse, and previously he was a very calm, nice child. So the oncologist who was seeing sent him to us for a PO workup. But he had already seen a cardiologist and had a normal workup. He actually had a couple times Holter exam off of his ADHD medicine, EKGs and echoes, all normal. I think he also had ambulatory blood pressure monitoring that was high the whole time. Okay, so at this point, I wanted to just think, okay, what are the symptoms? Because I know they're different in kids and adults. And up at the top, I kind of crossed out our usual adult triad that you read about with paroxysmal headache, palpitations, and diaphoresis that comes and goes. Because kids just don't tend to have that presentation. So they tend to have persistent hypertension, tachycardia, and headaches, but then all of these nonspecific yet worrisome symptoms. So I'm just going to read them because I wanted them to stick in my brain so I could have a higher index of suspicion. Blurred vision, abdominal pain, diarrhea, and constipation, weight loss, hyperglycemia, polyuria polydipsia, low-grade fever, behavioral problems, decline in school performance. And then if you have a paraganglioma, so an extra adrenal type PO, you may also have pulsatile tinnitus. It's at the skull base. If it's in the neck, you can have hoarseness and dysphagia, trouble swallowing. If it's in the bladder, you can have hematuria or a paroxysmal hyper or hypotension with palpitations when you urinate. And then hematuria with that. And sequelae that I didn't know about, Takotsubo cardiomyopathy, so a specific kind. Arrhythmias, pancreatitis, and then with the constipation, you can have it so bad that you have intestinal pseudo-obstruction, stroke, seizures, and multi-organ dysfunction. So you don't want to miss it. And these are the ones our patient had, bolded there. But how do you find it? So here's his meds. He was on methylphenidate. It's Jornay, which I think is a newer extended release when you give it 9. And then albuterol, Zyrtec, melatonin, simulator. Pulse was consistently over 125, so mostly 130s at all the visits I could find. Blood pressure 130s over 80s, height, weight, and BMI stable at the 20th percentile. He had some really classic NF skin findings, so he had some axillary freckling, cafe au laits everywhere, and then he had this really striking left forearm thing called phacomatosis pigmentovascularis, and I'll show you some pictures of what it was kind of like. And severe pectus excavatum, like wondering how he has a heart in there. It was really bad. So here's this thing, so phacomatosis pigmentovascularis is a combination of things. So I put a couple of individual ones. So it's a coexistence of some of these. So nevus spilus, which is this big kind of garden variety of various types of nevi over a large area of the skin. Port wine stain or other form of vascular malformation. Nevus of Oda, which is on the face, and Mongolian spot. So his, if you can imagine, instead of those being legs and arm, it was this big port wine stain. It was very red. Overlying it was kind of this lentiginous nevus or nevus spinous. So I think that's related to this rhasopathy thing, which NF1 is part of as well. But he doesn't have any bone stuff. So I know PHEO is challenging. And in adults, I think the time from initial suspicion to actual diagnosis is like 6 years or something. And it's like a really long time to be able to find it in people who actually do have it. So in kids, I don't know. And it can be anywhere. It can be in the adrenal gland, which is most likely in adults, but in kids, it can be anywhere in the parasympathetic nervous system from the skull base to the pelvis. And then in kids, it's more likely to be metastatic as well. at time of diagnosis. And then in NF1 patients specifically, I had no idea, so I went and looked it up, and 1 to 5% of NF1 patients get a PPGL at some time in their life, which is a significant, 1 out of 20. And the mean diagnosis is age 48, so still pretty rare in kids. And with that, even though it's super rare, they have 50 to 250 times increased risk, okay? And then, but this is good to know. So in NF1 patients, when they do develop a POPGL, it's usually in the adrenal gland and behaves well. So it's usually not metastatic, and it secretes both epi and norepi and those metabolites, which we'll look at. And as I said, it's rarely metastatic, which is good. And then here we have loss of function in the RAS pathway at NF1. And this specific mutation that you find in NF1 that causes PHEO may also be involved in a lot of sporadic PHEO cases, kids and in adults, so it's the same mutation. And I found a screening recommendation for NF1 to screen all NF1 patients age 10 and older every 3 years with a plasma and urine metanephrin. So, you know, you screen for it, it's important, but it's still not that common. Every 3 years is not that urgently that they're suggesting this. So what labs do I order? How do I perform them? Because I hear it's touchy. And then how do I interpret them when I get them? What imaging are we even talking about? And there's a whole nuclear medicine arm to this thing. And if I don't find anything, which I'm expecting not to find anything because of this long time to diagnosis in adults, then how do I monitor this patient? Do I do the every 3-year thing or what? So we'll look at this a little further. So what I found on performing the labs to try to minimize your false positives, well, first of all, plasma-free metanephrines and urine metanephrines. And most of the guidelines I found kind of left out dopamine. So, and I meant to put dopamine here instead of catechol. So when do you suspect a dopamine tumor? And I think the lines are really blurry here. And it would be, I think, a hard sell to say, get the norepinephrine and metanephrines, but don't get the dopamine. But maybe it looks like in dopamine secreting tumors, you have less hypertension. So if you have a normotensive or hypotensive patient, maybe you should really think about getting the dopamine. But I don't know if you should I don't know if you should drop off the dopamine from testing if they're hypertensive. But anyway, if anyone has thoughts, I'd love to hear them. And make sure you stop all interfering meds, which we'll talk about, caffeine and chocolate, 2 weeks before. So here's our pathway. We've got tyrosine, dopamine, and then norepi comes first, which I had forgotten about, and then epi is next. And then here's norepinephrine and metanephrine coming from those two. And I circled PNMT because this is something that could actually help you when you're thinking about your imaging. If you have epinephrine there, that means you have to the tumor has to be somewhere expressing PNMT, and you can't express PNMT without an astronomically high level of glucocorticoids, and that situation only exists in the cortex, the adrenal cortex. So if you have epinephrine that is convincingly high in your labs, then you can be a little more, you can think it's probably in the adrenal gland. But if you have no epinephrine at all, and then your norepi is sky high or your norepinephrine is sky high, you probably have a PGL and you need to look in the whole axis. And also for meds. So this is from a paper, I think in 2018. They had done a huge study on what medicines might affect your tests and give you false positives. So in blue here, these are the ones that do seem to affect the HPLC ECD method, and then a little bit of a shorter list in the tandem mass spec. So tandem mass spec is nicer because you don't have to tell them not to take Tylenol. But otherwise, you have to worry about antidepressants, tricyclics, and SSRIs, SNRIs, and then cocaine. But sympathomagnetics being the big one, because a lot of these have behavioral issues and they're already on Adderall, Vyvanse, whatever.
Can I interrupt? How long do they tell you have to be on?
2 weeks. Yeah. 2 weeks. Adderall, Ritalin, Vyvanse, Concerta, any version of this, and of course Jornay, which our patient was on at the time. Pseudoephedrine, so if they have a cold and they're taking a decongestant, you have to ask them if they're taking Sudafed or any of those combo drinks. Nicotine, cocaine, and DMA, and then caffeine and chocolate at the bottom to remind you. Because if they drink a soda, I don't know, is it going to throw off the test? Probably. Okay, and then so this is some biostats. If you have a low prevalence of a disease, a very rare disease, and this test that's not very specific, you're going to have a lot of false positives. So again, try to minimize those if we can. This is from adults. So 75% of eventually diagnosed PPGLs have convincing lab features. This is why it's so hard. So 25% is a huge chunk. But of those, 50% have both metanephrine and normetanephrines elevated, and that kind of shows you they're more likely to be adrenally located in adults. And then 25% have at least one or the other significantly elevated. Significant being 3 times the upper limit of normal. And if one of them's 4 times the upper limit of normal, it's almost 100% sensitive, specific. But 25% have borderline labs, so how do you proceed? So this is what we did. We ruled out hyperthyroidism a couple of times, and then we got our neuroendocrine lab. So the first time, it wasn't great. It was just a little bit of elevated plasma metanephrine, and the urine stuff was fine, and the dopamine stuff was fine. And then we repeated 6 months later, and everything was the same except the plasma normetanephrine was a little over 3 times the upper limit of normal. So that was really concerning, but we had not done anything to remove him from his meds. The first time he was on Adderall, the second time he was on Jornay. So I don't know, I looked on Lexicomp and they have different half-lives. The tests were done at different times of day. The medicines were given at different times of day. And if we go back to our table, maybe one of them, maybe Jornay's a 2+ here with normetanephrine. I don't know, so we don't have that specific data. So clearly we need to rule that out next time we test it. Oh, sorry. So that's what our testing looked like with him. So he was just normetanephrine elevated. So here we are. And NF tends to have adrenally located tumors, which should give us elevations in both. But you never know, he could not have an adrenally located tumor, or it could be related to his meds. So now when we think about what imaging we want to get, because we are concerned about this kid, we feel like we really do need to follow this up. How should we do our imaging? So let's look and see a couple different kinds. So the first line is MRI or CT, and in the kid they say go ahead and do the MRI just in case you find one, you need to do more imaging and you don't want to expose them to tons of radiation. And him in particular, if he has NF, I don't know how much radiation he's going to need. So we went with the MRI. And his was normal. And so then we wanted to do an expensive fancy nuclear medicine test, which we did plead and beg for and get covered, and it was a 68 gallium dotatate PET CT, and it was normal. Except the pectus excavatum was compressing all 4 cardiac chambers. I don't know, would that cause hypertension? I feel like it would cause hypotension. Anyway. So when I looked at this question, MRI and CT are usually most helpful if it is in the adrenal gland. So if you have a very elevated metanephrine level, or epi, you're looking at the adrenal gland. Not really helpful for PGLs. So if they're not in the adrenal gland, MRIs and CTs have a hard time finding. They just can be so tiny. And then even in kids, you can have really small adrenal ones, theos, and MRI and CT have a hard time with those. And any mets, you're probably not going to find in these. So then you need to look at functional imaging and try to decide what you are going to get. And maybe you can skip the MRI CT if you have just this elevation of normetanephrine, but that's going to be hard to sell for the insurance company. So here I put 3 different categories. So we have MIBG, which is kind of the one that's been around for a while, fluoro, something with glucose, and then this gallium, the one that we used, and an indium one. The MIBG is really good at big adrenal primary masses. Lots of false negatives with head and neck PGLs and metastases. Similar with the glucose, fluorinated glucose, but better at seeing small adrenophilia. So if you have a small one, but it's still in the adrenal gland, which how are you going to know from your labs? Then this test is better. And then these ones are really much better. The dotatate and the indium are much better with PGLs and mets. But they might miss adrenophilia. So you really, the epinephrine and metanephrine thing really helps, I think, with deciding which one of those to go with. And that's it. So we're going to see this patient again this month, and I'm gonna get the mom to stop the meds and the caffeine and the chocolate 2 weeks before. And we'll do the labs and plasma, and we'll do the urine. But I don't know, what should I do with screening with this kid? We were thinking yearly imaging, but what imaging? And anyway, that's where we are with this guy. Does anybody have any thoughts?
There's no renal or renal arterial pathology of any kind involved. The MRI would have probably.
Yeah, not by labs or imaging this far. Why?
With regards to the blood pressure.
Yeah. No, he's had a Doppler ultrasound as well. Yeah.
Did the cardiologist make much of the pectus as a possible
No.
cause of some of his symptoms?
Didn't.
In fact, just out of fun, I just looked it up, and it said severe pectus can cause hypertension, palpitations, syncope, and pulmonary hypertension. And
He's not having
hypertension.
syncope, but
I didn't know that.
Yeah, exactly, and that's what I said too. I said, can we talk to the cardiologist again?
What about, again, kind of on the issue of blood pressure?
Yeah.
When, at least for me, when I encounter those types of things, one thing that can be helpful is doing 24-hour measurements. So was it an ambulatory 24-hour blood
Yeah,
pressure?
and the cardiologist had done that, and it was elevated throughout. Yeah.
So, a comment and a question. We see these kids quite commonly, kids on ADHD medications, and with ambulatory blood pressure measurements, you sometimes get these high numbers, and then, of course, these kids just took their Ritalin, so their heart rate's really high. So, and some of them are losing weight, and they have headaches. So, all the symptoms that you're saying, I mean, we see those every day.
Yes, absolutely.
So, I guess my question is, how do you differentiate practically this child, which you did an excellent workup for FEO, but that is an exceedingly rare problem, versus a kid that needs to just go back to their doctor and talk about maybe changing up the medications before you kind of get into that.
Right. And they had changed him a couple times this year. And I think that Jornay, they were really hoping that it was like a kind of low extended release throughout the whole day, and it wouldn't be as as much peaks.
But now, I mean, you had that kind of almost normal metanephrine level in the beginning, and then you have normal MRI, you have a normal fluoridated scan.
Yeah.
So, what are you worried about?
Yeah, and I agree. I think that's where I am now after having just kind of looked through all this stuff.
It's a hard question.
I feel like we don't need to repeat all the scanning, and I think it does merit getting off the meds and trying to get some normal labs, but maybe not a scan.
Right.
I mean, the blood pressure measurement first, when it's off of the medicine.
Yeah, absolutely.
Yeah.
And one question at one point, I'm sorry, real quick. I mean, he does have the NF1, so I mean, you have a reason to be concerned, right? My impression of these kids, not that I've seen a ton of them, but a few, is that their symptoms and their hypertension tend to be more paroxysmal or episodic. I've never seen a pediatric patient just have sustained hypertension with one of these. Have y'all?
I mean, that's what I read about was sustained, but
most commonly described.
More just sustained?
Most commonly described as sustained.
But I've never seen. I mean, most of the kids I see are always paroxysmal. That's why I was
Are you
curious.
talking about kids with FEOs?
PPGLs and FEOs. Well.
Most of the kids. So I've seen one. I don't know how many.
And it's not a ton.
And it wasn't even me seeing them. It was me being on the floor when the surgeon was worried about it. And I think Dixon was the one on call that was taking care of them. So they're interesting. I guess we've had one here, right? Yeah, we've had one here. Yeah. So 2. I've been in the same state with one of them.
I think my index of suspicion is like way lower now after having thought about all this, and
Another question. In the paraganglioma pheochromocytoma syndromes, the STGD mutations, they're very clear. It's when the A develops after these many years, the B at this, and this one is extrarenal. Is the same in neurofibromatosis. Can you have a genotype-phenotype correlation? I don't know.
Yeah.
So genetic testing, maybe.
And what would I just send like a FEO panel?
So has to be, so in the pheochromocytoma paraganglioma, you will do all the mutations. And depending on the mutation, you develop your screening procedure.
Okay, yeah.
Because you know that the B is extrarenal and the A's are metastatic, and just to say something.
So maybe if we don't get a
Like
negative
if you don't get a
result.
mutation that predisposes to pheochromocytoma paraganglioma, you're probably more relaxed.
Yes.
If you have one, you say, oh, we have to do
Yes.
like whole body MRI every year or every 3 years, like the SDVG.
No, that makes sense as a guide, yeah. Oh, another thing I forgot was hypoxia seems to play a big role in some of the mutations. So hypoxia-related elements seem to have some role in the development of PO and PBGL in adults, sporadic cases in adults. And there's been a little bit more looking into toddlers and babies with congenital heart disease developing PBGLs more with this chronic hypoxic state. So don't really know why that is, but that's another association.
And one last question for the group at large. For you to get excited about an elevated dopamine level, does it also need to be 3x above normal generally? Do we have, I don't know, I have this one kid that I've been working up for one, and she keeps having these dopamine levels that are only 2 times above the level, upper level of normal, and I just don't know whether to get excited about that or not.
More than 2.
I don't know.
Pay attention.
Urine metabolites, I don't know.
I
guess if
MRI
they're
work is
elevated,
normal. I don't know what else to do. I'm in the same position you are.
Yeah.
And the other is one of our fellows is presenting, I think in this meeting, but not in the SSPR, a case of a child who is using multi-drugs, including cocaine. So it has hypertension, and it has behavior issues, and everybody thinks it's because of that. And we got convinced this has to be a fit. So put him in the hospital for a week and a half. So continuous supervision, everything, collected the urine 3 times, 4 times elevation, 5 times elevation, persistent hypertension. And he had a PO, took it out.
That's a high index.
That's a good
Stick 'em, stick them, I guess.
Yeah, I have a question.
Yeah.
I mean, I've never seen a patient in the field. I've never suspected anyone having hypoxic. I have no experience. So from pediatrician perspective, not from a specialist, this patient has been having hypertension all these years long. Are you going to treat hypertension even if you cannot diagnose PO?
I know, it seems,
Yeah, what are
and
you
he's
doing?
not on anything, yeah.
Yeah.
We're all deferring to the cardiologist.
Or
for
should
that,
you just
but-
let him have
Or maybe
Yeah.
you fix this pectus and then reassess.
Yeah.
Nespar? I don't know, is that gonna solve it?
Does he have a family history of hypertension?
I don't know that, yeah, I don't know that.
Is there like a preference, like serum versus urine metanephrine, which one is more sensitive? And the urine is a 24-hour collection, right?
Yeah, and in the guidelines that I was referencing, which I think are 2018, it says either or.
Either or,
Yeah.
But you did both.
Yeah.
Okay.
Would you?
Yeah, I guess so.
I mean,
Especially when you're not sure.
Yeah. All right, thank
Good
you.
job.